Yeah, thanks for the kind introduction again. Well, I'm the last obstacle before you can go to the drinks, so I will talk for the next 2 hours, and then we think about what we're doing. Now, I would like to pour a little bit of water into the wine, what Dale said, and I will just give you an overview what we think, or what I think now is known in dosimetry, particularly for lutetium treatment. Just come back to the lutetium decay scheme. We just saw some of the details, but there are two things that we have to bear in mind. One is that we have a good imaging quality because we have a 208 kV gamma emission with 10.4% emission probability, which is also good for post-therapeutic imaging, because due to the low gamma abundance, we can visualize, or we can scan high activities without running into much problems with dead time. And also, you see that the maximum beta energy is about 500 kV, so that has been shown by de Jong before. So the range is limited, and probably it's better for smaller tumors than for larger tumors. If we look at the lutetium spectrum seen by the gamma cameras, I apologize for the colors, but that is Siemens' original colors. You see here the 208 kV peak, and here you see the adjacent windows for a scatter correction. And if you think about using the second peak, you really have to be very, very careful with that, because first of all, you have downscatter here from the other emission lines, and also here you have some backscatter and LED X-rays and whatever, and so scatter correction for the lower energy window becomes really problematic. So in most cases, we now use only the 208 kV peak for scanning the patients. Just to come back and to remind you what we have to do for dosimetry, we have to measure the time activity curve, trying to be as quantitative as we can. The second step is the integration of the time activity curve in order to obtain the total number of decays in the organ or region that we look into. And we have to multiply, of course, with the corresponding dose factors, or fold it with the corresponding dose factors. And here's this is the equation of the taken from the MERD. So you have to integrate over the time activity curve, multiply it with the S value, and sum over all contributions of all organs, or voxels, or whatever structure you can imagine. And here's, again, visualized. So, talking about the steps to calculate absorbed doses. First of all, we need quantitative imaging, and that is the most crucial part, actually, that we have to bear in mind. Usually what we like to have is SPECT scans and SPECT CT scans, but we have some issues with the isotope energy resolution and all the things I've listed up here in order to really get a quantitative image. And some things can be corrected more easily than others, and I will show you in a minute what could happen. Particularly the calibration is an issue. Of course, if you have an integrated SPECT CT now, which is available in at least most of the sites that I know, or in many sites that I know, what we can do with the CT, we have the attenuation map. Scatter correction is also inherent. We have some morphologic correlation, which is also for dosimetry sometimes interesting to see where you are. And of course, it facilitates quantitative analysis. Calibration for gamma cameras is an issue, and I just like to turn your attention to a project of that was led by the National Physics Lab in England, by the Metro MRT, and it was for calibration for lutetium-177. And so what they recommended, and they set up a calibration protocol of spheres with 3 measurements, and with and without water, just to test how the attenuation correction works and also how the scatter correction works, and one off-center image, for example, to show that the image is shown, or the quantitation doesn't go wrong, or is not wrong if you're off-center. So that's one way of calibrating the cameras. There are other ways of doing that, but that is a crucial step. And also you have to bear in mind that the activity you have in your spheres, or whatever you use, should be somehow traceable to some standard. Otherwise, just measuring the activity in a dose calibrator might not lead to the right results. For example, what we're always doing, we just cross-check our activities that we use for our calibration protocols against a calibrated germanium detector, just to have a second independent way of measuring activity. Also, then, issue is that, here I show you some enlarged images of spheres, is that you have spill-out of the counts and partial volume effect, and that is more difficult to account for than it is for a PET system. Particularly if you go to smaller organs or lesions, you really have to bear in mind that. What we usually do, which is, well, not a very strict approach, is we enlarge in the region in order to include all counts. But what you also could do is to take the CT image and then correct with a correct partial volume effect factor, which is not so easily to derive. It's easy for spheres, but if you have irregularly shaped objects, it's quite difficult to correct for that. Also, this process is not standardized, so this is one of the major obstacles, or if you draw regions around the patients, if you have 10 people drawing regions, you end up probably with 10 different regions and try to get some, or you will get some variability in this. Also, what I would like to show you is that SPECT-CT is quite good in quantification if you use it in a very simple setting. Of course, this can also be applied to a more complex setting. This was a project that we worked on in collaboration with the International Atomic Energy Agency. And the issue was that there were cylindric phantoms and barium sources. And the barium sources, the activity was manufactured by NIST, and it was well known to a less than 1% inaccuracy of the activity. So that reduced the step of measuring activity in a dose calibrator and refilling it. So these were solid sources. And with this, we could show that the activity in a very simple object with a centralized reading here, that is the last point, is lower than, the inaccuracy is lower than 2% for SPECT-CT. If you look at planar imaging, it's 6%, and you see a larger variability. So we could show that multi-center trials are possible, because I think we have to work on that, because a lot of clinical studies are ongoing now and that rely on SPECT-CT and also planar gamma camera images for calibration. And we have some traceability here with this barium source. Unfortunately, for lutetium at the moment, there's not a good support or not a good replacement isotope. And of course, we showed that SPECT-CT provided best results. So I think for dosimetry nowadays, it's mandatory at least to have one SPECT-CT scan for a good quantification. Of course, you can get by with a SPECT if you know what you're doing, but the further or the more you reduce the technology you have, the larger the uncertainty will get. The second step is, if you want to calculate dosimetry, is the integration of the time activity curve. And I saw just some slides on a 4 data point, and just like to show you this nice example on kidney dosimetry, published in 2013 by the Italian group. What happens if you omit data points or if you do the wrong type of integration? So for example, you have 5 data points here, stop at 70 hours. And then if you do a mono-exponential fit, or if you do a bi-exponential fit through the 4 data points, omitting this 1 data point, you end up with almost a factor of 2 in the area under the curve. But that is directly related to your absorbed dose. That means if you don't do the right fitting procedure, you end up with a potential factor of 2 in the absorbed doses just by the integration process alone. Also, this shows nicely that a late time point, particularly for lutetium imaging, is important, because then you could reduce the uncertainty a little bit, at least at the late time points. This is always, of course, a matter of debate for clinical trials, that people want to scan early because the patients leave, which is understandable, but for dosimetry, the last time point is the most crucial time point, actually, because that determines the rest of the area under your curve for lutetium. And this question led us to develop a software for calculating time-integrated activity coefficients, which also provides some standard errors and error propagation, which is not the case if you have 4 time points and you use a bi-exponential fit. You get very, very good results, and the error will be 0, which is unrealistic. And also, this software gives you some parameter and some ideas. What is a good fit procedure and what is a bad fit procedure, or not so good fit procedure. And this gives you a choice of function to determine how to do that. Of course, you can program this yourself. With experienced programmer with MATLAB can do that as well, but that makes life easier if you have something that you could use. Third step for dosimetry is to calculate the S value. And for this, the least you can do here, you have the standardized model of Olinda, for example. the least you can do is for self-irradiation to adjust the mass of the organ you want to quantify by the real mass of the organ of the patient. Of course, this is also for kidney dosimetry a little bit critical. You take the cortex, you take cortex or medulla, but you have to see, and usually the activity accumulates not in the medulla. And then you have to calculate this correct for this. That's the first order correction. Of course, it would be better to just use a voxelized approach, just voxelizing your patient, put this into a number cruncher dosimetry, fill this with the dose values and the S values with the patient-specific S values, and calculate your patient absorbed dose on a voxel base. If this is really necessary for all cases, is a very good question. For lutetium, probably you can get by with just a simpler dosimetry, but if you think about beta emitters with longer range, then you have to take this into account as well. So, what we know and what we do not know on dosimetry. We have quantitative imaging, but we do not have a real standardized procedure for calibrating SPECT-CTs and gamma cameras. This is just not the case. The void drawing is also somewhat arbitrary. We have to think about the optimal number of time points for scanning, and well, my recommendation is always try to go for more than 4. Optimal fit procedure is also a matter of debate. It's not so easy sometimes. Also, the question, what is better, voxel-based versus organ-based dosimetry, has not been resolved. And if you look at different software solutions, they provide you with different results. There are solutions on the market, but the real test objects are still under development. And of course, the role of commercial software is also, needs to be enlightened, and there's some drawbacks, and you have to know what you're doing also with the commercial software. And also, as I said, the testing is absolutely needed. The second part of my talk is devoted to more measurements of the absorbed doses to the kidney and the bone marrow, and showing also some of the variabilities that we have. 2 years ago, we just compiled some of the data that were available in publications, for example, on the absorbed doses to the kidneys, and you can see that there's a high variability in the gray per gigabecquerel, so the specific absorbed doses here, which is mostly devoted to the difference between older or planar methods and spec-based methods. But still, you see that there's almost a factor of 2 in between. Interesting to note here is also that there's a difference between pre-therapeutic absorbed doses and post-therapeutic, but this is related to that there was no kidney protection performed for the pre-therapeutic scans in this work. But again, you see a high variability. Also, if you look into the patients, and we saw some nice examples today as well, you have a variability in the patient, and it's not that the one-size-fits-all approach fits really all patients. For example, here, that's the work by Sandström from the Uppsala group, shows that the kidney absorbed doses, the mean in 200 patients was about, for a standard activity, was about between 4 and 5 gray. Liver doses usually much lower. Spleen doses are in the same range, but as far as I know, there are no real dose limits for the spleen absorbed dose to the spleen. Also, we have to think about what we do with kidney toxicity, and you've seen this, maybe you've seen this example. So this is the kidney biologic effective dose, and this is a derivative, or it's derived from the physical absorbed dose by including repair, and this is the mu factor here, and the alpha over beta ratio, that is tissue related sensitivity. And with this, the authors could nicely show that there's agreement between external beam data and data taken from radionuclide therapies for yttrium-90 and yttrium-86 recalculated for yttrium-90. On the other hand, there's one outlier, and it's not clear how this outlier comes, or how this outlier is really can be taken into account. And also, we have to think about if this is really applicable for lutetium-90, because, for lutetium-177. Because if we just do the same calculations using the same factors, we see that for the absorbed doses that we have here for one cycle, which is between 5 and 10 gray, for example, the difference between the BED and the absorbed dose is rather minor. And if you think about the normal 4 cycles that we're having, also the difference between the BED and the physical absorbed dose is not that large. So most of I think we can get by for lutetium treatment just using the physical absorbed dose because it's closer to the measurements we have. But this is a matter of debate, and needs still to be enlightened further in the future. Second issue is the absorbed dose to the bone marrow. Also, we have here high variability in the data that we've seen. Again, this is planar method, and this is based on blood measurements, which might not be representative for the real absorbed dose to the bone marrow in this case. Also, we have here, interestingly enough, we see a good agreement between pre-therapeutic and post-therapeutic dosimetry, and this is also based on the 3D method. So it seems that the 3D methods show higher specific absorbed doses and show higher specific absorbed doses. Again, we see a huge variability in the patient. This is, again, the data from Uppsala, but also showing that you have individual variations in the patients, which is to be expected. So the one-size-fits-all criterion also doesn't hold true for lutetium dotatate treatments. Also, there's some facts or some experimental facts that support that there is a red marrow uptake after DOTA-TOC therapy, and of course, it's not unexpected maybe to see also some effects in lutetium treatment because the compound is similar. And here nicely the group from Belgium could nicely show that there's a dose-effect relationship between the red marrow BED, that was a substitute measurement, and the number of decrease of platelets here in the treatment. And those two data were taken from from radiation accident data here. So there is some effects, and we have some red marrow uptake, and if we increase the absorbed doses to the kidneys, or if we overcome the limit of 23 gray to the kidneys, we might see another toxicity in patients of the bone marrow. So that's the next critical organ, I think, in lutetium treatment. And also, you've seen this this morning in the talk of my colleague. We can measure the double-strand breaks after lutetium peptide radiotherapy, and we see that we have an increase, a dose-dependent increase, and a decrease over time here. And most of the damage is repaired, but we still need to interpret what happens in this case if the data are still higher, or what happens after repeated therapies. And this is still research ongoing, but this could be an interesting add-on to bone marrow dosimetry to see how double-strand breaks really behave in the medium in vivo in patients. So in patient studies, what do we know? We know, or we've seen, some data showed differences in kidney biokinetics between the cycles, some didn't. So I think we still have to look into this patient specifically. We don't know what the optimal number of cycles are for lutetium treatment. Actually, I've seen papers with 8 cycles or 10 cycles. These patients were still treated, but what is really the optimal number is just not clear. Again, also the 23 gray limit that is usually imposed upon us by authorities if we go for clinical trials is most likely not the good limit, but we need clinical trials to show that we can exceed this limit. We need data and not anecdotes that really show us that we can go higher. We need systematic studies on going that. I'm pretty sure that we can get by with 30, 35 gray absorbed dose limit to the kidneys, but these data are still not really available or are still missing. It's just an add-on information of many trials, but not done in a systematical way. Last, not least, we need to discuss if the biological effective dose is a better parameter than the absorbed dose. Also, methodology-wise, we have to think about the best way to calculate the absorbed dose to the bone marrow. And of course, we would hope, like Professor Meyer de Jong showed that new biomarkers can predict toxicity of the bone marrow or maybe also tumor sensitivity. That's also a very, very interesting approach, I think. Okay, last but not least, before you can go to the drinks. So we have 3 steps to successful dosimetry in nuclear medicine, and we have to carefully look at all of the steps, not only quantitative imaging, but also the integration of the time activity curve and the S values. And we have dosimetry, as Dale showed nicely, has been successfully applied in clinical applications, but we still need better standardization. And of course, as I said, we have some time points, treatment, bone marrow toxicity, and some other questions I already raised. So we have to really go onto that. And also as a medical physicist, we have to develop our methods further to prove better support for clinical trials. And at the end, I would like to thank you, the staff of my department, and particularly some people, of course, the ENM Dosimetry Committee, because some of the work we did was good collaboration between the colleagues within Europe, and of course the patients, because the patients provided their data. And with this, I would like to thank you.
Thank you very much for this excellent talk.